and then I'll have like some questions, very few, don't get too nervous. So the first part, I'm just gonna switch over to my notes here. It's much easier because you can see colors and maybe that'll help retain some information. So the first thing I'm going to talk about are some numbers I want to get out of the way. I have, in 1 liter of NS, you have 154 milliequivalents of sodium. In 3%, you have 3 grams per liter. And 1 gram salt tablets has 17 milliequivalents of sodium. Normal range is 135 to 145. We all know that. We should know that less than 125 is considered severe, and serum osm is above normal range if it's above 320, and if it's above 420, it's fatal. It's kind of easy to remember 4, 3, and 4. So the basic workup that we send for hyponatremia includes the BMP. Oh, you can't hear me? Okay, I'll speak a little louder.
Yes.
So the normal workup we send is a BMP, a UA, urine specific gravity, and osmolality, and that gives us serum osm, urine osm, serum sodium, urine sodium, and urine specific gravity. We also need to take into account volume status, and sometimes TSH level, you can send it as well. And I'll talk why volume status is important in differentiating different types of hyponatremia. I also want to just get the pseudohyponatremia out of the way as well. It's just when you have a lot of osmotically active solutes like glucose, your high protein, high lipids. It's basically a lab artifact where it changes the fraction of water in a lab tube and gives you falsely low sodium. For every 100 or so increase in glucose, you can subtract 1.6 point of sodium, but it's also a range, and relationship is pretty much non-linear once you go up to 400 milligram per day of glucose. So if you're me, just use MedCalc and have them solve it out for you. I'll get to the symptoms of hyponatremia. Majority of the time when we have hyponatremic patients who come from outpatient setting, they have a more prolonged period over which they'll drop their sodium, so they're better. That prolonged drop is better tolerated, so they usually don't have much symptoms. But if you do have acute drop, then you can have symptoms, and I separated them by mild and severe. So if you're usually, we have people less than 130 and still asymptomatic, but we don't know often if they've been less than 130 for a while or not. So they're not asymptomatic. But if you're just you dropped or less than 130, you'll have irritability, difficulty concentrating, headache. You'll lose some weight. And what is dysphagia? That's just something I copied from the symptom list. It's basically just, does anybody know? I'm curious off the top of your head. Crickets. Oops, so.
What's the question one more time? I'm sorry.
Dysphagia. It's one of the symptoms of mild hyponatremia. 1, 2, 3. It's just change of taste. I also learned it when I was preparing this, so I didn't know what it was. You taste like metallic or something else. And then you can be irritable. And severe hyponatremia, which is concerning, which is what we should look out for in our inpatient population, and most importantly, seizures, because that's something that can present early, and we can catch it before the patients can complain about it. You can have nausea, vomiting, you can have cerebral edema, and this neuromuscular excitability undergoes the same category as seizures, and then you can have permanent neurologic injury, and it can lead to coma and death. So, diagnosis. So this is where I'm gonna spend most of my time in. It's the chart, and the reason why I preferred this format is because just like by the time I finish talking on this slide, you can like kind of take a picture of this in your mind, and then it'll help you forever. Um, so remember how I was saying that we do workups: serum sodium, serum osm, urine sodium, urine osm, and specific gravity. So the first thing we check here is you can go either way. You can go like other algorithm where they divide by volume first, but in this specific table we have first thing you have your serum osm. So if your serum osm is normal, then you know that this may be like we were talking about pseudo hyponatremia, meaning you may have extra protein in there or triglycerides, and it's just reading it wrong. If your hyper osmolar state over 290, this is you're osmotically diuresing your water because the water is following the sugar molecules in your urine and sodium is following the water. So that's your underlying cause for hyponatremia. We can fix that. Sometimes after giving diuretics, mannitol, people pee it out, and that can cause hyponatremia. Next is your hypotonic hyponatremia. That's what we are going to talk about mostly. So here your body's osmolality, the serum osmolality is low, you're more dilute. So how can you do that? You can drink a lot of water and just dilute out entire intravascular volume, psychogenic polydipsia, and you just you're hyponatremic. You did too much. You want it to be too healthy. So in that case, your kidneys should be able to excrete water more. So your urine osmolality here can be, it should be low, because you're basically getting rid of all the extra water you're getting because you have a healthy kidney. But if you have inappropriately concentrated urine, like here, this is bad because now you have a problem of hypoosmolar state in your serum, and despite the fact urine is wasting all your sodium. So I'll go over the two main ones. So basically SIADH and salt wasting right here. Well, these are the two pathology we're going to talk about. In SIADH, you're either euvolemic. So in the volume status here, you're either euvolemic or hypervolemic, because your ADH level is inappropriately high, syndrome of inappropriate ADH, antidiuretic hormone release. So because you have too much ADH in the kidneys, they retain all the water and not the sodium. As a result, your sodium level, urine sodium level, is usually high. Although they can't really explain why this body is not trying to save the sodium, that it's unknown. But for our purposes, for us to diagnose, now we have normal to high volume, and a urine to serum osm ratio of 1.5 to 2.5 to 1. It can also be just 1 to 1. But bottom line is that your serum osm is low. And in diagnosis of SIADH, you have to exclude other pathologies like thyroid abnormalities, adrenal dysfunction, where they're just hypocortisol, lack of cortisol, you're just not retaining sodium, and as a result, you're becoming hyponatremic. But those pathologies also come with their own set of problems, so you can also look at them to make sure you rule out hypothyroidism and other adrenal dysfunction. And the start point that I have is euvolemia on SIDH. And I'll get to in cerebral salt wasting, on the other hand, right here. The start point is that it is hypovolemic. So if we follow down this path here, your volume status is decreased, and your sodium, your kidneys inappropriately concentrating the urine. So that's why you have this greater than 20 milliequivalents of sodium in your urine. They're just there's no reason why this happens, but there's many hypothesis of why the kidneys fail to concentrate urine in the setting of intracranial abnormalities like strokes and subarachnoid hemorrhage. And subarachnoid hemorrhage is one of the biggest one, 6% of subarachnoid hemorrhage. And this is data from before, so I'm not sure if it's higher now, but 6% of them have cerebral salt wasting. And so the key thing that we have to remember is that the SIADH is euvolemic and salt wasting is hypovolemic. And it's important because the treatment of SIADH and cerebral salt wasting is opposite. In SIADH, you give volume, and I'm going to go to treatment in a second. And salt wasting, you don't give volume, you do fluid restriction. In salt wasting, you give extra volume. And it's important because if you don't give the extra volume and if you restrict fluid, then you can worsen the intravascular volume and can exacerbate vasospasm and DCI in salt wasting. So we don't want that. So those are the key differences. And then there are some other conditions like your GI loss, and then you have like the CHF cirrhosis situation where it's just you have too much intravascular and extra cellular fluid in the CHF and cirrhosis that causes you to lose too much sodium. And here you have renal failure where the kidneys inappropriately concentrating the urine are not saving the sodium, despite the fact that your intravascular volume is increased and your osmolality is decreased. It's just the kidneys incapable, like your nephrotic syndrome and things like that. So let's get to the next page. So here I listed a whole bunch of, actually, before I go there, does anybody have questions about this? Everybody fell asleep already? Man, I really didn't want to be boring. That was my primary goal.
We're all with you.
You're not boring, Fatima. I think everyone, you're explaining it so well.
Thanks. So, so the causes, I mean, I'm not gonna go over all this. Okay, I don't have to. I took it from Greenberg, and basically, I highlighted the ones. We have your ICP, elevated ICP situation where you have hydrocephalus, subdural hematoma, Sabarac, which is kind of crazy because you get both SIDH and Sabarac in both SIDH and cerebral salt wasting is subarachnoid hemorrhage. So it's kind of hard to like. There's also a challenge, a diagnostic challenge, if you want to say. Commonly, we see non-small cell lung cancer usually present with SIDH. However, SIDH is the most encountered problem in inpatient population, because if you look through these lists, a lot of people have this infection, pneumonia, and this was kind of crazy for me to find out also. Apparently positive pressure ventilation can cause it, but how many patients we have on, so all of our patients are at risk for SIDH. And if you look at their home meds, so every time you see hyponatremia, low sodium on admission or later, you check their home med list. And often you'll find Tegretol and oxcarbazepine and SSRIs, hydrochlorothiazide. I never saw vincristine in any of those, but I mean, I never really correlated NSAIDs with hyponatremia, so now I'm going to. And if you give, ignore my notifications, and you can give like DDAVP too much to cause SIDH. So this is the treatment, and I focused on the treatment because everything else like these peritonemia, glucose elevation, all of this, you can just fix the underlying problem, and that's kind of the solution for it. I just focused on SIDH treatment and salt wasting treatment. So when it comes to SIDH, I briefly alluded to it before. You restrict fluid. When do we restrict fluid? When patients are not severe, and which is less than 125, or they're asymptomatic, or we don't know how long they've had hyponatremia. You just restrict the fluids. You can do 1 to 1.5, but so when I was reading, there's something called solute ratio you can follow to decide, but I don't think we do that. I think we just do 1 liter for most people. And if they're like super large and obese, then we do 1.5. And then you have you can give salt tablets, and sometimes you can give medications. Demiclocycline comes with some bad side effects, so we don't give that, but we sometimes do bring up your vasopressin receptor antagonist, the tolvaptans. So I'll get to tolvaptan in a second because I want to just go over the other two situations. So if it's really severe, less than 125 and acutely happening, so even though we're not supposed to give IV fluids, we're supposed to restrict fluids, you can in that setting give 3% and give Lasix at the same time, so it's waste of water. And then in severe, when it's still severe but no symptoms, you can give NS and Lasix. So these are your 3 treatment tiers. But usually at that case, we'll just like go to our neurointensivist and make sure we're doing the right thing. But quick question. So remember back then I said NS has 154 milliequivalents of sodium. It's a question, so be ready to answer. And your serum is 135 to 145. So technically you're giving more hypertonic than even though it's closer to isotonic, it's more hypertonic than your serum. So why can't we just give NS and call it a day? Can somebody explain? Hi, I'm sorry. I'm like that annoying person, but I really want to hear it. No.
Fatima, could you repeat the question?
Yeah, so my question was that since NS is 154 milliequivalents and our serum sodium is 135 to 145, it is slightly hypertonic than your serum sodium basically. Why can't we just give NS and call it a day for SIDH?
Does it have to?
Mm-hmm. Go ahead.
Is it because of the fluid restriction you said? Is that what you implied?
Fluid restriction. Yes, sorry, somebody came in. Everyone's sleeping. I'm sorry. I'll be back in just 1 second. Who's this?
Early Amazon deliveries every time.
Sorry, guys. So
Yep.
what were you saying? Sorry, I missed it.
Is it because some of the sodium is going to go out with the water? You're talking about when you give it with Lasix? If you give this with Lasix,
Yes,
it's going to go out with
exactly. Yeah.
water,
So
higher concentration.
thank you, Lauren. That makes sense, right? So you give the NS and you don't give loop diuretics or anything. It's just going to retain the extra volume that you're giving, and it's still going to waste all your sodium. So you're making it worse. So if you give the Lasix with it, at least the Lasix can waste both water and sodium, but I'll get to it, a net effect of retaining more sodium than actually losing it. Thank you so much for the participation. I'm so proud. So then I have the treatment for salt wasting. So in the salt wasting, we have to replace volume because salt wasting, you're losing the salt. That's your pathology. But with the salt, you're losing the water as well. And like I was saying, in Sabarak, we're always chasing euvolemia. We don't want hypovolemia and worsening with DCI. So this is why it's critical to distinguish, and we should give volume. We should not give Lasix. And then we give salt tab, and then we often add Florineth. But just have to keep in mind, we're often not cognizant of the fact that it does cause very bad hypokalemia. Refractory hypokalemia has been mentioned in literature. So if we're noticing hypokalemia and we notice that patient's sodium's been improving, in that case, we can discuss bringing to like just stopping it or just coming off of it. So just to explain, I know we don't use loop diuretic a lot for hyponatremia. It's usually used more for like the CHF here. But loop diuretics, they basically lose your sodium and your water, and the net effect is basically improvement of hyponatremia. But at very high doses, they can cause renal dysfunction and other toxicity. And then also, if you over diurese a patient, their ABP, basically ADH, is upregulated, and then they start retaining water paradoxically. So you're not really helping at that rate. So here you can see this is the sodium in heart failure patient. They did this. So with the higher doses, their sodium improved over time. And then urine output also stabilized over time. And so that's why it's recommended. All right. So here, I'm sorry, I kept too many participation than I thought. So I'm going to fill this out with your help. Can somebody else other than Lauren, Vadim, and Arthur participate? So water in SIDH, what is it? Or water for volume interval, is it high or low in SIDH?
High.
High. Oh, oops. Oh, I thought it was someone else other than Vadim. And salt wasting. Low. I'm just gonna, for time's sake, I'm just gonna do this. I don't know who wants to participate. Serum sodium is in SIADH is what? Low. We're talking about
Just
hypernatremia.
pick the name.
Pick the name. I can't see the screen, so you pick for me if you don't mind. I don't know who's actually in the call because I'm screen sharing.
We have Alma, Brianna, Lauren, James,
Brianna.
Brittany, Arthur.
Oh, perfect. Perfect. Brianna, sodium in urine in SIDH, low or high? Oops. Okay. Okay.
Might be wrong.
Whatever. Whitney. All right. I'm getting crickets, so I'm just gonna fill this up. So sodium in urine in SIDH is high. Both of them, they're high. Osmolality, serum osm is low. Serum osm is low. Urine osm is both high. So these are our diagnostic, points, and they're all pretty symmetric. So we're not getting much help from lab work, but hematocrit should be low on SIDH and high in salt wasting. And then I have this chart from Dr. C that's very helpful, that has come into use many, many times. Thank you, Dr. C, if you're in the call. All right, so I'm just going to switch over to my PowerPoint here. Can you see that? Can you guys see my PowerPoint? Okay, perfect.
Yeah.
So I basically went through everything here. I'm gonna just talk about the stuff that I missed. So central pontoon myelinolysis, any sodium talk is kind of vain without CPM diagnosis. So we just have to remember 8 milliequivalents in 24 hours. And then these are the changes in MRI right here. Oops. Right here in midbrain. So this is the reason why basically it's called shearing of the axonal sheath, and you can basically be forever in a vegetative state from that. I talked about salt wasting. We talked about that. And so last thing, I'm going to talk about hyponatremia here. I just had some questions that I thought people would be more participating more a little bit. So I was going to do like a discussion format, but I'll just go over it for time's sake. I have 2 minutes, 2 more minutes. So basically, there.
We don't have bounds.
Oh, okay. I just saw it. Oh, perfect. Okay. Okay, perfect. So this paper was very interesting because for those of us who found the previous part of the talk pretty much kind of everything that we already know, this is, I don't know, to me it was a little new. I was kind of trying to find the kind of like the ceiling effect of doing hypernatremia treatment for induced hypernatremia, for people who we want to raise the sodium for whatever reason to reduce ICP. So so then I came across this idea that hyponatremia, induced hypernatremia, the efficacy of it in a bolus format versus your sustained dose where you're just giving hypertonics for a long time, which we tend to do a lot. So this is what this paper talks about. And I know this slide is a little busy, but I'll break it down. The first 2 points, they're just talking about all these physiologic changes that happen that causes cerebral edema or swelling in different states. So you have your cytotoxic edema, where the sodium potassium pumps stop working, and then you have like the ionic edema, and I'll show you the channel in a second. And you have vasogenic edema, where the endothelial, the walls are dysfunctional because of blood-brain barrier is impaired. So the way these hyperosmolar mannitol therapy and bullets, the hypertonics therapy, the way they work acutely is that you give it fast, and if you give it acutely, they just draw out the fluids from the interstitial space and then reduce swelling. A few other points before I go into the chronic therapy or like longer time therapy is that it is found to be helpful in post-op cases where you have swelling post-op. It helps more so than your ICHs and your strokes and subarachnoids. But in general, 145 to 155 was the range where it can help without major adverse effect. It talks about it right here. And then you have, they also found that hypertonic therapy can be better than mannitol in some cases. And the other thing is, if you do too much hypertonics, let's say we have a lot of patients over 156, 150, it's actually not good. It overall, it can, it worsen, it's associated with worse outcome score. So we have to be careful about that. But in that study, they used numbers like 170s, 180s. Thankfully, we don't reach that level. But it just goes to show that hypernatremia at certain level can reach a ceiling effect in helping the patient. And then also there are other studies that correlated these hypernatremia with poor outcome. But it's just like, did they have higher sodium because they were sicker to begin with? And so it's just underlying disease severity, or is it really like hypernatremia causing poor outcome in patients? So that's the difference. So back to our question about whether bolus is better or whether bolus and sustained hypertonics both work the same way. Actually, they found in this review that sustained hypertonics can actually be harmful because the effect of ICP reduction in studies showed that it kind of like muted down after 72 hours. And then it also came with its own slew of renal side effects and things like that. So this is it's also a busy slide, but I just want you guys to focus on the picture really quick. It's just this diagram I'm going to talk about. So even though like in an acute situation you are drawing out the fluid from the swollen up cell, but if you keep on giving the hypertonics, you're creating a situation where it's just a hypernatremic state. And in this state, you can activate response from this pump. And so let me go back to hyponatremia. So in your hyponatremic state, your cells swell up because the water coming in, but you have this channel here, the SIR2 and KCC, but basically channels that pump out the sodium from the cell to bring it to the physiologic state. In hypernatremic situation, they also don't want to cause damage. So physiologically speaking, this sodium potassium ATPase pump, it pumps sodium back in the cell to make it into turn it into a normal cell volume. So if you keep the patient in hypernatremic state for a long term, you can do this where you just basically get sodiums to go more into the cell. Does that make sense? And induce induce brain swelling, basically. So there's also, they also talk about brain resetting and then not helping. So that's something to keep in consideration for our clinical practice every day. Like, oh, this patient has ICP crisis, this and that, but how long do we keep it hypernatremic? And one last thing, I always wondered, I never really did research into it, but like, does sodium bicarbonate really alter serum sodium? And it does. Interestingly, I came across this study, basically, not study, sorry, this article in Emergency Medicine Forum, where they were saying how that, if you come into the emergency room and you're hyponatremic and you started seizing, and they're going to take some time to, can you lower your volume? So you take some time to lower the sodium, then sorry, I'm distracted. So a patient come in hyponatremic and you don't have 3%, they have to prepare it, and you don't have it. Pharmacy has to prepare it. So you can actually go to the crash cart and take 1 ampule of sodium bicarb, which has about 51 milliequivalents of sodium, and you can help the patient that way. So I'm way above my time. I'm gonna stop screen sharing. I don't want to do DI because I kind of 8:35. Do you guys want me to do DI or?
How long is
It's
your
up to
DI
you.
talk?
It's also, I mean, I kind of want to do the DI stuff. I can just go over it really quick. But
Yeah, I wanna listen.
Okay, awesome. All right.
Whitney has decided. Thank you.
All right. Thank you,
Thank you,
Whitney, for
Arthur.
wanting to listen to it. One sec. So I'm just sharing my screen again. Sorry. DI, very quickly, it happens from your again, cerebral pathology, things that has to do with your posterior pituitary stalk. Let's put it this way, and that way you can link most of these different causes I listed here: craniopharyngioma, very commonly after transsphenoidal, from direct injury, meningitis, and other tumors. But one thing is craniopharyngiomas are more found to be more causing more DI than your regular old pituitary adenoma, even if it's very high. So in DI, I just wanted to differentiate between nephrogenic and central. We never almost deal with nephrogenic. That's like due to some medications and hypokalemia, and things like that. But we just focus on the central diabetes insipidus. So in central diabetes insipidus, you have high urine output, and then you have polydipsia, and people are thirsty, and then your sodium goes up. There's three types after surgery that's commonly seen. You have the transient one, which is mostly seen, where it's just transient DI post-op. We do 1 or 2 doses of DDAVP and it's gone. There can be some people who go into the prolonged DI and they need DDAVP forever. We've had few patients like that. And the triphasic actually is the least common. I thought it was always triphasic. So I'm kind of learning a lot. So the triphasic one is basically you injure the pituitary stalk and the ADH goes down, and then your cells start dying and then liberate the ADH, and then you normalize. And then if your cells die, all of them die, then you may be permanent in your third phase, or you can actually come back to normal ADH level. There are some other differentials I listed on the right-hand side here. Often we have brain death patient on vasopressin drip because they are in DI. We have central herniation. When people start downward herniating, they can shear the pituitary stalk and go into DI. And skull fractures, I've never seen it personally. Phenytoin apparently does it. I didn't know that, and I never saw that. Neurosarcoid. And then, so diagnosis. I'm going to skip this slide because diagnosis mostly in our hospital, we follow Dr. Bookber's protocol, which is your urine output has to be over 250 cc's for 2 hours. Then your spec grab has to be less than 1005. And then you send the serum sodium. If it's over 150, you give the DVP. But if you look at the literature here, they're not really saying 150. I don't even know what they're saying here. Yeah, I don't know what they say, but they're just mentioning hypernatremia. They don't care like 150 or not. And also, this is a water deprivation, so we never do this thing, so I'm going to skip through it. Treatment for DI, you drink 2/3, patients drink 2/3, and they can compensate it. Then recently we had a patient, who compensated very well through liters and liters of urine. And then in that case, you can keep the Foley if you're suspecting DI, you do Q4 BMPs. And at that point, if you meet all those Bookverse criteria, you can give a DDVP. So just to differentiate, IV is 1 microgram and PO is 0.1 milligram. So just to keep in mind. And in our case, we'll probably call endo and get their help at that point too. So that's all, guys. How do I stop this? Did you guys like it? Did you learn something?
Yeah, thank you.
You're welcome. All right.
Interesting about the amp having to go to the Omnicell. Someone's crashing sodium that way.
Yeah. I learned about it too. All right. Good to present. It was fun preparing and doing it. I did it last night. But I'll see you guys tonight.
Thank you, Fatima.
Does anybody have any questions? I mean, I think I like that like slidey presentation format. That was really nice. It was cute. There's some good graphics. You got to show us that later. And I hope people have some good takeaways. We can't learn everything. You said there was a lot of information, but some very important points like the DI and sort of what Dr. Bookvar likes. What we do here is very important. So I'm glad you mentioned that. Versus getting too deep into the science of it. And this, hopefully, we can upload this for those who want to review it. But does anyone have any questions now for Fatima, since she's like knee deep in sodium?
Drinking salt. You can also send it in the chat if you end up listening to it later or anything. But yeah, so just to keep in mind, I did not like, I omitted a lot of the things that, we would think irrelevant. So it's not something that's applicable to like the outpatient setting or everywhere else in the hospital. It's just very neurosurgery specific. All right. I see Roni joined. All right. So thank you
Thank
so
you,
much,
Fatima.
guys. Thank you. I'll see you guys later.
Bye. Thank you.